Hi, I'm Dr. Peter Tolosano, Director of Psychological Services for the Connecticut Department of Developmental Services. I'd like to welcome you to our video entitled A Positive Behavioral Support Approach for Developmental Disabilities. This is our third video in a series of 3. I'd like to introduce my co-presenter, Dr. Tracy Sondick. Dr. Sondick and I have both presented and published on the topic of positive behavioral supports. Welcome, Tracy.
Thanks, Peter. It's nice to co-present again with you on this topic. I am the Director of the Behavioral Intervention Service at Connecticut Valley Hospital, part of the Department of Mental Health and Addiction Services, and we are excited to present on this important topic on positive behavioral support plans. I'd like to begin the discussion today about positive behavioral supports and this approach by considering the question, is it possible for an individual to change their behavior? Most of us go into this profession around helping people with challenges by having a deep appreciation for how difficult it is to change behavior. Anyone who has broken a New Year's resolution or set a goal and quickly found that the goal was difficult to achieve recognizes that behavioral change is challenging. There's no single solution that works for everyone. We often expect individuals to immediately change a behavior that they have been struggling with. Oftentimes, this is a behavior they've had for a lifetime, and it's been repeated and reinforced over time. So we have to remember when we start a positive behavioral support plan that we're striving for progress rather than complete change overnight. Progress toward a new behavior takes time, and rather than perfection, we're working toward a process of change. A positive behavioral support approach is a comprehensive perspective that looks at the whole person. Traditional support approaches for challenging behaviors typically followed a medical model. A medical model simply is a model where maladaptive behaviors are conceptualized as a sign of an underlying disease or problem, rather than serving a particular function. That is, for example, if someone is displaying an abnormal behavior, it is because they have a particular diagnosis. For example, Joe acts out because he has schizophrenia. That's just how he is. So that would be a medical model approach. The idea that there is a problem and that there is an expert that can remedy the problem by giving a prescription or giving certain interventions. So it's expert driven. There's a person who knows the answer. A positive behavioral perspective is different. It's not incompatible with a medical model approach, but it is a more holistic approach because it views behaviors as goal-directed. The behavior is serving a purpose. It's interconnected with the person's unique physiology, the situation, their developmental and psychological upbringing, thoughts, feelings, and culture that they live in. So this is a comprehensive approach that includes all of these different facets. In addition, it is not expert-driven. The person is at the center. The consumer and the family and their supports are at the center of the plan, rather than someone coming in and saying, this is the solution to the plan. So these holistic approaches are at the heart of a positive behavioral support approach.
As we delve further into the topic of positive behavior support, let's better understand the definition of the term. So if we think about it in the phrase support for positive behavior is what is desirable, adaptive, and pro-social, meaning it helps the individual to make progress in their life. Support means to be encouraging to increase positive behaviors or to strengthen the existing ones. This is as opposed to a non-positive behavioral support approach, which would use aversive tactics, humiliation, stigmatizing, and so forth. The positive behavioral support term was adopted by Rob Horner in 1990. Another key figure in the field is George Sagai, who developed positive behavior interventions and supports for the school system back in the late 1980s. So when we think about positive behavioral support in practical terms, there's some key ideas. First, as Tracy mentioned, PBS is centered on doing a functional assessment, which is an information gathering process. We'll be talking about that a bit later in the video, more so in depth. The second part is that we use comprehensive interventions, meaning we use proactive techniques, intensive strategies, crisis plans, reactive strategies, and so forth. We're very key on developing lifestyle enhancement, improving the quality of a person's life through person-centered planning. And lastly, when possible, we try to advocate for a team approach, meaning there's collaboration to support the process. In the way that we describe positive behavioral supports, we have added to this model, as Tracy mentioned, in a comprehensive way across time, and that's reflected in the video today.
So often people will ask, what is the difference between a positive behavioral support and an applied behavioral analysis, or traditional ABA model? So I want to first start by talking about an ABA approach. So applied behavioral analysis is analyzing the interaction between purposeful behavior and a changeable environment. So that's what a traditional behavioral analysis is. A positive behavioral support includes looking at the interaction between behavior and environment. So it includes an ABA analyzation, but it also includes other key factors that make it an ABA plus approach. First, it includes a normalization and inclusion movement, allowing a person to live in their natural environment, to be part of society, to be included in school systems, university systems, work systems. It's person-centered and family-centered, and the values are emphasized from the person's unique family. We're also using contributions from different models, from medicine, from biology, from developmental psychology, from neuropsychological interventions, and empirical research. So it's an integrative approach. So the main difference, just to reiterate, is that a positive behavioral support plan includes an ABA approach in addition to other modalities. So what are the key components to a positive behavioral support approach? First and foremost is the idea that teaching is the foundation of a PBS approach. So it's proactive teaching of expectations, acceptable behaviors, and skills. Second, the approach includes building on existing behaviors that are already functional or working well for a person, building on strengths. So it's a strengths-based approach. There is ongoing monitoring of problem behaviors. This is often more of that traditional ABA approach of data collection and analyzing the behaviors. And then data-driven in terms of making decisions and evaluating the effectiveness of the plan. We'll spend some time in the video talking about the importance of data collection, how it can help inform the decision and make a positive behavioral support approach truly empirical. There's an intense effort to really support a person so that they eventually can become more independent in their skill acquisition. Improving quality of life is really the cornerstone of any PBS approach. We want people to feel happier in their lives, and we know that when people feel happier, there are less behaviors of concern. And finally, there's an integration of this implementation of skills and how a person responds into their daily life.
The following slide reflects how comprehensive a PBS approach can be. So the slide entitled "A Holistic Approach" looks at all the different variables that are involved in PBS planning. Everything from family and social determinants to behavior, to sensory issues, to interests and cultural values, to education supports, to medical issues, and also community involvement. One of the things that individuals have indicated is helpful is oftentimes when we talk about a treatment paradigm based on an individual's level of intellectual disability. In reference to this slide, you can look at the first video that Tracy and I did on understanding intellectual disability to better understand those particular levels. If we start at the bottom of the slide, individuals with a severe to profound level of intellectual disability can benefit from positive behavioral support with an emphasis on environmental strategies. When we move up to a moderate level of intellectual disability, we can use skills building, as Tracy mentioned, an emphasis on teaching, as well as a positive behavioral support model. And lastly, when we come to a mild level of intellectual disability, there's a plethora of different techniques that we may use. Positive behavior supports, psychoeducation, and also psychotherapy in various formats.
One of the key components to understanding a positive behavioral support approach is understanding a person's readiness to change. When I spoke in the beginning of this presentation about the difficulty in changing a behavior, especially a behavior that has been learned over a lifetime and being reinforced, it's really critical to understand a person's readiness. This gives some key clues to where to intervene and what particular interventions might be most effective. So I'm going to discuss a bit about the stages of change so that we can better understand what kind of interventions might work depending on the stage of change. So stage of change model goes back to Prochaska and DiClemente's model of understanding how to work with addiction. And they found over time that the stage of change model could also be applied to behavioral change, even for people that have severe behaviors of concern. We can apply the stage of change model to individuals, to families, and systems. And it's critical to understanding where a person, individual, and system are on this stage to plan accordingly. So I'll speak about the first 3 stages of change. The first stage of change is called pre-contemplation. Pre-contemplation refers to a stage of change where the primary characteristics are denial, poor awareness, or sometimes even rebellion. When a person is in a pre-contemplation stage, or when a family or system is in a pre-contemplation stage, the goal at this point in time in terms of a positive behavioral support approach is really education. It's helping to raise awareness and consciousness in a soft-hearted approach so that a person doesn't become defensive or rebellious. We want a person to begin to understand that there's a discrepancy between their goal and what is actually happening behaviorally. So a pre-contemplation stage is the most challenging stage to work with because often a person's not really committed or ready for change. The second stage is contemplation, and contemplation is really characterized by ambivalence. A person, system, or family are displaying mixed feelings, emotions, and behaviors. On one hand, wanting perhaps to change a behavior, on the other hand, very stuck or committed to the same behavior that might be causing the difficulties. So stage of change language starts to emerge in this contemplation stage. A person may say, I wish I could stop doing this. I want to improve my life. So that is a clue that a person is beginning to emerge into a contemplation stage. The goal at this point, in terms of an intervention from a positive behavioral support plan approach, would be to explore with the person what is the function of the behavior. Avoid dwelling on the negative consequences, but helping them understand how this behavior developed, and that can be a roadmap to how to begin to make changes. The next stage is preparation. This is when a person, system, or family are making steps toward change. So the person may be taking proactive steps by getting ready to make a change, maybe beginning a psychotherapy session, starting to make changes in their daily routine, or at least coming up with some concrete steps. From a positive behavioral support approach time, this is a critical time to help a person begin to develop the skills to make the changes that they want to do. Usually in a preparation stage, a person is within 30 days or so of actually implementing a plan. So there is some readiness that needs to happen before the plan can be implemented.
To continue in our discussion about stage of change, this is a model that I've used throughout my career as a backdrop to all of the different services that I have provided. The next 2 stages of change are action and maintenance. So action follows preparation, as Tracy just described, and action involves when a person is able to demonstrate a commitment to a plan in real life. And then maintenance. The person is able to stay changed for at least 6 months, and there's a focus on relapse prevention skills. Allow me to give you a story that illustrates the stage of change model and the importance in understanding how the intervention is only as good as the assessment that drives it, and the importance, as Tracy reflected, of having a match between the stage of change and the intervention that's selected. Many years ago, I was working with a couple on a detoxification unit, and the wife, throughout the conversation, was mentioning to her husband, who had just completed a detox 30-day process, that he needed to go to Alcoholics Anonymous meetings and to get a sponsor. This gentleman did not respond to any of her suggestions in the meeting, despite the fact that she repeated them. And I asked him a question which is based on the stage of change model, which is, what do you think about your drinking? Despite the fact that he had just had inpatient treatment, his response was, I don't think that I have a problem. In that case, when you apply the stage of change, illustrates how he is in a pre-contemplative phase, whereas his wife is suggesting an action-oriented strategy. And again, that mismatch will not yield positive results. Some other general considerations to consider. People change into and out of problematic behaviors. People vacillate between stages and phases of each stage. And then also, one of the things clinically that we tend to find is that the transition from contemplation to action tends to be the most difficult. Stage of change model is not a linear one. People may make progress and then revert back to older behaviors. And again, we want to avoid mismatches between the individual's readiness to change and the intervention that is offered. Coming back to a more traditional positive behavioral support approach, we have a flowchart here, and it really describes all the different facets of using a PBS model in the way that Tracy and I practice it. Individuals who have seen this slide have suggested that it's a really good template to use when doing consultations. So if we look over the slide, at the center of it is identifying the function of problematic behavior. And then if we work from left to right, we see person-centered planning on the left, so understanding the goals, strengths and weaknesses, barriers and resources in place for an individual or family. And then more specifically, getting into the setting events and precursors or predictors to problematic behaviors. The foundational and lifestyle strategies, so preferences, activities, routines. And then also as we move to the right, proactive and reactive strategies. Again, this is a template by which to look and say, have we looked at all these different areas? And then lastly, but also quite important that we want to look at up front in the PBS process, are any physical, medical, physiological, psychological, or social determinants to behavior.
So Peter has talked about the importance of a functional assessment as part of a positive behavioral support approach. We already talked about a small component of a positive behavioral support functional assessment when we talked about the stage of change model. That is a part of a functional assessment, understanding a person's readiness for change. I'm going to go into some other really key factors in terms of a functional assessment. Remember back to the previous slide around a medical model approach versus a PBS approach. One of the key differences is this functional assessment. A functional assessment really takes into consideration multiple factors when understanding the function of a behavior. So first, I'd like to describe something called setting events and vulnerabilities. Setting events refer to situations in the environment combined with an individual's deficits or weaknesses. And this is in reference to a problem behavior. So they could include something very broad that's been an ongoing issue. For example, if someone has unsteady blood sugars related to diabetes, poorly controlled diabetes, they may have ongoing internal physical distress. If someone has an undiagnosed seizure disorder. So these are broader setting events that could impact a person over time. So we always want to look at the physical. In that previous slide, Peter was talking about the physical, physiological, and psychological factors. So this is referring to those factors. What's going on in the person on an ongoing basis? And also for many of the individuals we serve, they may have sleep issues, they may have medication side effects. All of these are considered setting events, even though they may be slightly behind the scenes if one is not looking for them. So we can turn these setting events into positives if we understand them. So the key is to really do a very thorough interview and history review to understand what is actually happening for the person in their medical health, their daily routine and activities. The more vulnerabilities, the more setting events a person has, the greater likelihood that this may manifest in behavioral issues. The second area in a functional assessment that's critical to understanding a function of a problematic behavior are antecedents and triggers. Antecedents refer to what happened immediately before the behavior. Antecedent, that's what the term means. But a couple of nuances that are important to flesh out. Is it a fast antecedent or a slow antecedent? In other words, is it something that happened right before the behavior, or is it something that had a slow but ongoing effect? So an example of a fast antecedent would be a loud noise in an environment. And after the loud noise, the person immediately started yelling, right? So if someone's overstimulated by the environment, the antecedent is the loud noise, and then the behavior is the person's screams, for example. A slow precipitant or a slow antecedent might be something that happened a few days ago. Perhaps it's the anniversary of a loss, or it's something that upset them a couple of days ago. A family member wasn't able to visit if a person's staying in an inpatient setting. And then 2 days later, there's a behavioral episode. And that would be an example of a slow precipitant. And it may not always be obvious unless a thorough interview has been conducted, not only with the individual, but the person around the individual, caregivers, staff, family members, to understand, especially the slower precipitants. Sometimes they're harder to identify. Additional antecedents to look for, external. So it might be something happening within the environment with a peer, with a family member, with a person in authority. And it also could be an internal antecedent. So for some of the people we serve, it might be a feeling of loneliness, despair, psychotic thoughts that are disturbing in content. That can also be an antecedent to a behavior. We'd like to look at lifestyle considerations as well. People that are more vulnerable to having problem behaviors often have less social supports, a lack of relationships, or difficulty accessing preferred activities. A person may like to go to the gym, but they may not have the financial resources to get that kind of physical activity. And that physical activity may have helped decrease the likelihood of a behavioral episode. So we want to look at that lifestyle issue, the accessibility for preferred activities. And finally, it's important to consider what we might call universal triggers. What affects a lot of people in a negative way? And one of the key universal triggers that Pete and I have both discovered in our own work, and we know that the research supports this as well, is an enforcing or authoritarian style. And this, we know, can cause people to have a rebellious or sometimes negative way of responding. So when we begin to talk about interventions later in this presentation, we're going to talk about giving flexible guidance, support without doing it in a rigid or authoritative way.
Thank you, Tracy. Just to circle back to the setting events and vulnerabilities, an example that I typically share during the presentations that Tracy and I do is in an event where in a geriatric setting, an individual suffering from dementia who had significant short-term memory deficits was given multiple step directions by staff, which led him to verbal aggression because he became so frustrated in the fact he could not keep pace with what was being asked of him. And the intervention was simply to give him 1 or 2 step directions at a time, which removed the setting event and it allowed the verbal aggression to extinguish.
So that's why it's so key to understanding the setting events. The functional assessment gives us a roadmap because once we know the setting events, we can try to avoid them or decrease them or eliminate them altogether, which can then decrease the likelihood of a behavior.
To Tracy's point, one of the key hallmarks of positive behavioral supports is to minimize or eliminate any type of antecedent or trigger from the environment. One of the things that I also want to note with regard to functional assessment is that oftentimes, particularly on the DDS end of it, when we review positive behavioral support plans, is that individuals use the term functional assessment and functional analysis interchangeably. Unfortunately, those two terms are not synonymous. A functional assessment is what Tracy and I are describing currently in the presentation, whereas a functional analysis is actually manipulating the environment, if you will, to bring out a behavior in order to see what variables are influencing it coming to the surface. Moving along with the components of a functional assessment, several more items that we think are very important. And again, all the information contained here in our presentation are things that Tracy and I have added in over years of experience, and we're highlighting things that we think are most important. So several other definitions. Precursors. So sometimes people confuse precursors and antecedents. As Tracy mentioned, antecedents are triggers, whereas precursors are noticeable changes in someone's body language that come before the behavior of concern. Pacing, pressured speech, rolling one's eyes, clenching one's fists would be examples of precursors. And again, when we get farther along in the presentation, the distinction between antecedents and precursors becomes an important one based on whether or not we're going to use proactive or reactive strategies or a combination thereof. And then lastly, maintaining consequences is a crucial variable to understand in a functional assessment. And in maintaining consequences, what occurred immediately after the behavior of concern? How did the caregivers respond? Is there inadvertent reinforcement? In other words, how we're trying to respond to the behavior of concern, does that in and of itself become a trigger for escalation? We're going to speak more specifically about functions of behavior. And the presentation slides show a chronology of how understanding function has evolved over time. So if we look to the left, initially, functions were viewed as either having positive or negative reinforcement. In other words, they were either adding something for that individual or taking something aversive away. As the field evolved, we began to look at intrapersonal reinforcement, in other words, something that was occurring that was positive within that person as a result of the behavior, or interpersonal reinforcement, so something between that individual and someone else, for example, as the slide depicts, help-seeking behavior. The following slide is the model that Tracy and I oftentimes rely on in better understanding why individuals with developmental disabilities engage in maladaptive behaviors. And this model comes from the work of Robert Sobner back in the early 90s. So according to this model, there are 4 possible functions to a behavior. Again, we try to look at things comprehensively, and sometimes it gets quite challenging when you have clinical complexity in the picture to distill it down to a single function. And on that point, a behavior may serve one or more than one of the particular functions that we're going to describe. So the first function, and this is one that we oftentimes hear, is that the behavior of concern serves a communicative function. In other words, the person doesn't have the ability to access language to communicate their needs, wants, or feelings, so they oftentimes resort to physical action to convey what's happening with them. The next possible function of behavior is that the behavior modulates internal distress. So for example, anxiety, unpleasant emotions. An example of this might be self-injurious behavior with cutting, which releases endorphins and helps an individual to calm down. The third possible function of behavior is that the behavior modulates or regulates some type of physical distress or discomfort, or pain for that matter. So a couple examples of this would be many years ago when Tracy and I worked together in a hospital setting, we had a lady who had significant amounts of irritability and verbal aggression. Unbeknownst to us, she had significant GI issues that would wind up requiring surgery to ameliorate, and once that occurred, her verbal aggression mentally subsided. Another example on the DDS end of it is we tend to see individuals who have some type of physical pain, for example, dental issues, who do not have access to language, and they may engage in striking themselves, for example, in an effort to try to regulate that pain that they're experiencing. And then lastly, a possible function of behavior is that it provides the individual with social or environmental control. And one of the things that Tracy and I try to convey is that the need for control is something that oftentimes needs to be depathologized. In other words, we tend to have a very negative view on looking at individuals when there's a control function to behavior, but control and mastery are something that is built into us as a survival mechanism, and we all need a sense of agency, if you will, in our lives to feel like we're having an impact. So again, just to recap, a behavior may have one or more of the particular functions that are described.
And I think to Peter's point too, that many of the behaviors might have started out as adaptive. In other words, trying to maintain control in a chaotic environment for someone who may have undergone some adverse childhood abuse was a very adaptive way of surviving. But a behavior can become maladaptive over time due to a different environment that a person is in, or that the behavior is no longer serving them. And I think the other point of doing that thorough assessment and understanding the function of the behavior, it takes away some of the negative stereotypes people have about someone who has a behavior of concern. It puts it into a perspective and a context, which is really important in terms of working with family members and caregivers. So a couple of key points when we're thinking about functional assessment of behavior. The first point is really crucial, the idea of teaching proactive skills. And we talked about that as one of the central components of the philosophy of a PBS approach. So teaching adaptive behaviors essentially helps render maladaptive behaviors unnecessary. So if we teach a person how to regain social or environmental control, for example, so that they feel like they have agency in their life, the maladaptive ways that they may have been trying to do that, for example, let's say that they use threatening language to get control, that becomes unnecessary as they develop more confidence in their ability to actually maintain control in functional ways, which might be to meet with a clinician or to write down or write letters if there's a concern. So we want to be teaching adaptive behaviors. That's really the cornerstone. The other piece that's really important when we consider a positive behavioral approach is that we often over-apply the idea that a person is attention-seeking or manipulating to get their needs met, and misunderstanding the true function of behavior. That's why the slide where Peter talked about the different functions is really critical to help people not get into that oversimplification that they're doing it because they want attention. That also can be demeaning to the person, and you may be missing the point of intervention where we can teach applicable skills to render the maladaptive behavior unnecessary. So to better understand challenging behaviors, we have to learn to ask the right questions. So the first question that caregivers, family members, and people providing services need to ask is the challenging behavior a symptom of a medical problem? We talked about the setting events and how setting events could be related to an ongoing medical situation. Working with the DDS population and DEMIS population, we have people that we serve that have a variety of medical issues, and they may not be able to verbalize that they have pain in a particular area of the body, or even notice if something isn't comfortable. They may just have a behavior that reflects that discomfort. So we want to make sure that we rule out a physical issue. Number one, physical issues are often easier to treat. It may be simply, like Peter was saying, getting good dental work, or relieving GI distress, or a medication change that's needed. So we want to start with that idea of remedying whatever is possible in the physical domain. So lab work and physical examination, sometimes neuroimaging, just to rule out and make sure that a person is healthy and there's not something that could be addressed easily. The second is the behavior a reflection of the side effect of medication? And now this is a very nuanced question because many of the clients and people we serve have different medications and often are on polypharmacy, multiple medications to treat different conditions. And side effects are a real problem and part of daily life for many of the people we serve. So we want to find out if it's a side effect of the medication, are there other options for the person, a different medication perhaps, or other ways that we can work with them to overcome that side effect. The third part is the challenging behavior part of a chain or a cascading effect? Does it reflect something that is actually an ongoing difficulty, or is it just something in itself a problem for that day? So we want to look at the whole context of behavior, not just what we're seeing moment to moment. Is the problem behavior a skills deficit? Is the person simply acting in a particular way because they don't know how to do it differently? We make a lot of assumptions if we haven't done a thorough functional assessment to really understand a person's behavior. That's why often both Peter and I suggest doing psychological and neuropsychological assessments to understand, does the person really have the capability to control their impulses, for example? Do they have the capability of understanding the consequences of their actions? Again, having that understanding can help us with the interventions and also understanding their stage of change and readiness. Over and over again, I've been amazed once we do a comprehensive assessment that often people that we serve have areas of skills and also deficits that we may not have even discovered. For example, if a person is having trouble keeping up with their hygiene, for example, maybe they're having difficulty showering, maybe there's an unusual body odor, we may assume that they are not taking good care of themselves. They're intentionally not engaging in self-care. If we call upon our occupational therapists or our nurses to do a thorough evaluation, we may discover the person doesn't really have a good understanding of how to do their own activities of daily living. So the functional assessment's really crucial in understanding and asking the right questions. And finally, really looking at the quality of life. It is a huge undertaking, but also extremely important to understand what a person's quality of life is. Is what is happening now acceptable to them? What are their personal choices and preferences? What makes them happy? And this question, although can feel like a very large question, is really instrumental in helping a person to live a happier life. So these are some of the key questions we want to make sure we're asking the person that we're working with, along with the family and caregivers and staff.
An example that illustrates how skills deficits may be an underlying influence to a behavior of concern centers on adaptive skills. In the video on understanding intellectual disability, Tracy spoke at length about understanding adaptive functioning. I had a case many years ago of a young lady who was trying to live independently, and one of the concerns that her caregivers had was she was refusing to go grocery shopping. And we looked at this as a behavioral issue. The actual cause of her reluctance to go shopping was that she was given a debit card for the grocery store and she didn't understand how to use the debit card, and she felt like she was going to be embarrassed when she got to the cash register. So what seemed to be behavioral was actually cognitive in nature.
So I'd like to spend a little bit of time now talking about the caregiver qualities. And why this is so important is that when we're teaching new skills and we're providing support to the people we serve, we want to make sure that the support that is being provided is helpful. We spoke earlier about the universal trigger. When a caregiver or a staff member or a clinician has an authoritative or very rigid approach, we know that this can actually trigger a behavior of concern, often unintentionally. So that's why it's crucial to really spend some time doing some training and education for our caregivers and staff so that they fully appreciate how they can best help the person in learning new skills. So these are qualities that both Peter and I have found to really be helpful in terms of implementing positive behavioral support plans. So first is supportive. Truly, the person needs to feel like the person giving them interventions is on their side, that there is support for them, rather than telling them what to do, that they're joining them. Respectful, always an underlying quality that is needed in a clinical or family support system. Strengths-based. We want to have the positive behavioral support plan focus on strengths, and we also want the caregivers to focus on strengths, to provide often and positive feedback around what they're seeing that is positive about the person they're working with. Sometimes when there's a maladaptive behavior, everyone around the person focuses on that behavior without recognizing all the strengths and the good things that the person is doing every day. So it's really important to be strengths-based in terms of giving feedback and working with what actually is already a positive activity or way of being for the person. This next part is really important, collaborating, not controlling. And often as caregivers and staff and clinicians, there are subtle ways that we might be controlling in trying to help a person move their behavior along. But we know through our stages of change model that the more that we are trying to be controlling, if this is a mismatch from where a person is in their readiness, we actually can cause a burst of maladaptive behavior, or a person may even regress to a previous stage of change. So collaborative means joining them at the stage of change that they're at, not trying to control the person, but actually being right where they are with them. Empowering goes hand in hand with the collaboration. Empowering is really important. If a person feels empowered, they have more agency. Over time, they begin to live a life that they want to live versus feeling like other people are trying to tell them what to do or control them, which often then cycles back into some of the maladaptive behaviors. So we're empowering, and that is done through giving choices, through positive praise around strengths, can make a big difference in terms of a person's progression. And finally, building self-esteem. This is no small task for all of us in terms of building self-esteem. But when a person begins to feel good about themselves, when they feel their own intrinsic value, we see that more and more those maladaptive behaviors become incompatible with the person that they want to be. For example, if a person starts to feel genuinely good about being polite, about being liked, about being fun to be around, we find that they are less inclined to yell, scream, or engage in negative behaviors with other people because they're enjoying and feeling good about being someone that people like to be around. I have an example around a positive behavioral support approach that I used with a client in an inpatient setting. This client was very aggressive and often got into arguments and sometimes physical altercations with peers. Part of the positive behavioral support plan was to find situations where he could be helpful and a friend to other people. So he got a small job working in the lobby of our inpatient ward, where he would do some light cleaning and support a coffee cart that was part of the lobby activities. Over time, he became more and more friendly, and people started to come out and talk with him. He enjoyed sitting and talking with peers and having the reputation of being someone who was fun to be around. What I saw over time was that the behaviors of concern, the aggression, the negativity toward peers naturally fell away as he began to identify himself as someone who was likable, positive, and pleasant. So the key factor in resiliency and helping people change is really a person feeling like other people believe in them.
To dovetail into what Tracy just mentioned, we can even look at the importance of caregiver qualities through a psychodynamic lens. Attachment has a mirroring function. And our sense of self, which is comprised of self-identity, as Tracy reflected, building self-esteem and so forth, not only comes from ourselves, not only comes from our own accomplishments, but it also comes from what people reflect to us about ourselves.
So as we work with people that have positive behavioral support plans, it's really important to be a good consumer, to look at the plan and make sure that it's addressing the needs of the people we serve. So a good approach, a positive behavioral support plan that is a good approach, is person-centered. We always want to respect the dignity of the person. We want it to be individualized and strengths-based. We want the person to be informed and be willing to participate. We want it to be the least restrictive plan, and we don't want it to be a cookbook approach. Sometimes behavioral plans have the reputation of being a cookbook approach, meaning that it's the same techniques used over and over again. We know if we did a really thorough functional assessment that the person has individual unique strengths and limitations. And so we want to make sure that the interventions match that, which is certainly not a cookbook, but would be their own individual prescription. We want to focus on the positive changes in the environment. So how can we support a person in making the changes? And then how can we generalize those changes across different settings? For example, when I construct a positive behavioral support plan in an inpatient hospital setting, I also want to keep an eye out on how the person can utilize these skills once they're discharged and into the community. So we want to make sure that the skills that are being taught are not so unique and specific to one setting, that they're good generalizable skills so the person can function across different areas. We want to eliminate negative consequences. So positive behavioral support plans don't include negative consequences. They don't include taking away or using coercion or restrictions, which in fact actually have negative consequences over time. It doesn't teach a person new strengths, and it can reinforce a person's negative self-esteem. And finally, it also can undermine a person's dignity. So we want to avoid at all costs taking away a person's dignity and respect. So a positive behavioral support plan is incompatible with negative consequences, coercion, or restrictions. And finally, collaboration. We talked about that as a quality for caregivers, but a quality also for a positive behavioral support approach in general. So collaboration really means first helping caregivers understand the approach we're using. So training is really key. Both Pete and I have spent a long time when we create plans and making sure that the caregivers, providers, and family members are on board with the plan and understand it. And making sure that there is a sense of a team approach, and it's an interdisciplinary team. We spoke earlier about that medical model approach where there's an expert at the top and there is not that ongoing collaboration. With a PBS approach, we're talking about an interdisciplinary team where the person we serve is at the center, family is at the center, the clinicians are at the center, everyone's at the center because it's truly a team. And that way there's not one person that's responsible, everyone is sharing and working together. And finally, as part of that feedback of the team approach, we want to make sure that there's a way that the communication is ongoing. We want to have feedback loops so that we can see how a new intervention is working and also modify if something's not working. So it's critical to have ongoing consultation meetings, times where everyone at the team can get together at the table and talk about what is, the most important thing that's working, maybe what is not working, making modifications, and also seeing how these skills might translate into a new setting. So feedback is critical to an ongoing positive behavioral support plan approach.
One important point to emphasize when we're talking about collaboration is that we do so when it's clinically indicated, which is by and large many of the instances that we're involved in doing PBS work. However, the caveat is offered that there are instances, for example, when we have behaviors that an individual may engage in, such as problem sexual behaviors, fire setting, that are risky to the community. And at that point, the level of collaboration may change, and we certainly want to get buy-in by all the individuals involved as stakeholders in an individual's care, but there are instances where sometimes that is not possible, and again, we have to do so to protect the community. So some helpful techniques when implementing positive behavior supports. First of all, language needs to be clear, consistent, and concrete. Break things down into smaller parts. In all the years I've been doing positive behavioral support work, oftentimes, especially for caregivers, we put things out in language that's complex, sophisticated, and we simply overlook asking the person if what we're saying makes sense to them. We want directives to be broken down again into smaller parts that are accomplishable. For instance, only clean half or a quarter of the room to start. It makes it more manageable. We want to offer the person 2 or 3 choices, oftentimes that lead to a similar outcome, to provide the person with a sense of control. So completing a chore, when doing de-escalation techniques, and so forth. This is not about bargaining, because bargaining may lead to confusion or agitation. This is simply offering things in a clear, concise way that is streamlined to a particular set of outcomes. We want to give immediate reinforcement. In other words, we want to give explicit verbal praise within 1 minute rather than delaying it. I know Tracy and I have both seen instances where an individual with developmental disabilities is receiving praise for something that happened a week ago where they may not have a recollection. One exceptionally helpful technique is the use of something called compassionate inquiry. It comes from the world of cognitive behavioral therapy, and it's helping the individual build a positive sense of self. As the example on the slide points out, what does a particular behavior say or tell us about you? And oftentimes we can link that behavior to a positive attribution or a centering construct that the person finds very inviting and helpful. So for example, being a gentleman. And then lastly, one of the techniques that Tracy and I like is something called critical scheduling. So building a daily routine around the fact that less preferred activities are followed by more preferred activities to increase motivation. Very similar to the Premack principle. So for example, and again, pay attention to the language, it's not if then, it's when, after, or first you take a shower, then we go to lunch.
So in terms of other terminology that you may come across in a positive behavioral support plan, we want to go through some of those words carefully so that you have a good understanding of what these components mean. So the first is positive behaviors, and we use the word target behavior to reflect the target that we're aiming for. Sometimes this term is used to describe a maladaptive behavior. So depending on what type of behavioral plan you're reading, you may see target behavior as the problem behavior. But in the work from a PBS perspective, the targeted positive behavior is the behavior that we want to help the person learn, instill, and maintain. Okay, so the skills and teaching component goes hand in hand with the development of a targeted positive behavior. So here are some key or crucial targeted behaviors that we often address in a PBS plan. One is emotion regulation, the ability for a person to be able to regulate their emotions so that they can have a healthy response. Over and over, we see that the maladaptive behaviors are often related to internal distress. Pete talked about that in the Sovner slide as one of the functions of behavior. So we know that when a person has difficulty modulating their emotions, which can also relate back to some brain abnormalities and difficulties in the limbic system of the brain, we know that they may have difficulty with self-soothing and coping. So part of the teaching of positive behavioral supports is around helping a person develop self-soothing, coping skills, and healthy diversions to help a person manage their emotion regulation. This is really foundational in terms of being able to move forward in one's life, is being able to regulate one's emotional flow. So that's one area that we focus heavily on in terms of target positive behaviors. Often it's the groundwork before we can move to higher level skills, is helping a person develop emotional regulation and stability. The second area is helping a person become more adaptive in terms of building independence, autonomy, and mastery. Eventually, we want someone who is working from a PBS approach to feel like they got this on their own. They're able to do this. That's that mastery component, where it becomes no longer necessary to have someone cue or coach. The person has developed the skills on their own. And this, we see this in many different settings. For example, a job coach who might be very instrumental in the beginning in terms of helping a person stay focused on their job, cueing them, giving them specific directions, to being able to fade out over time so that the person is able to do the job much more independently or completely independently. So teaching adaptive skills to really help the person develop autonomy. And finally, the last piece that is really crucial is pro-social skills. So we are relational as humans, and it is really important to be able to relate to people and to have a positive interaction as much as possible with people around us. So helping people develop pro-social skills. Many of the people that we serve have social skills deficits. it perhaps related to autism, as we talked about in our second video, or other difficulties in frontal or executive functioning where they misread or have difficulty understanding social nuances. But these skills can be taught, and so that is often a very important part of a PBS approach, is helping a person understand how to relate to someone else, maintain a conversation, and enjoy shared activities. So this goes to the quality of life aspect. We know that when people have an improved quality of life, it renders many of those maladaptive behaviors unnecessary.
Tracy's example of scaffolding, in other words, offering someone support as their mastery develops and then fading that support away, is a really great one to help someone build adaptive skills.
So a second component in terms of understanding PBS language is a behavior of concern. And so rather than even saying maladaptive behavior, which we did discuss earlier, what a maladaptive behavior is, but behavior of concern has a more neutral terminology to it, and also it's really about the idea of decreasing or eliminating a behavior of concern, and eventually substituting it with either a replacement behavior or a targeted positive behavior. So behaviors of concern might include verbal outbursts, verbal threatening, physical aggression, property destruction. It could be something called perseveration, which means getting stuck on one particular item, action, or person. It could reflect in poor boundaries or poor social skills. And also refusals, or what we call non-adherence. So refusals to participate in treatment or programs or medication. So all of these can be behaviors of concern. And one of the hallmarks to understand a behavior of concern is the idea that a behavior of concern interferes with functioning, interferes with daily functioning. So it rises to the level of interference. All of us have some behaviors of concern that we might like to eliminate, but if it doesn't rise to that interfering of regular life as the person knows it, it is not considered a behavior of concern.
So what are the criteria specifically for a behavior of concern to tie into Tracy's last statement? So behavior of concern poses a risk to the health and safety of the individual or others. Behavior of concern may interfere with his or her personal growth, development, or progress. A behavior of concern may interfere with the person's ability to make decisions or achieve their goals. And sometimes a behavior of concern may result in a psychotropic medication being prescribed to try to modify that behavior. We have intensive efforts on the DDS end of things to minimize that last mechanism. But again, we have some very clear criteria around what constitutes a behavior of concern.
And to Pete's point, recently I received a consultation asking for a behavioral plan for a client who smokes. And when we look at the behaviors of concern criteria, while there may be some negativity associated with health-related risks, etc., the question really was, did it rise to the level of a behavior of concern? And in fact, it wasn't a problem for the person that was smoking. So in that case, a positive behavioral support plan would not have been appropriate unless the person really was invested in making a change.
So the next slide shows a hallmark area of positive behavioral supports, which is proactive versus reactive interventions. And we're going to talk about this at length. As you can see on the slide, Ben Franklin's quote, "An ounce of prevention is worth a pound of cure." Proactive interventions are far more effective than reactive ones typically. So the slide shows the difference between proactive versus reactive strategies and the benefits of using a proactive approach. So if we look across the first line, under column A, interventions that are proactive prevent the problem behavior. When using proactive interventions, we place an emphasis on teaching alternative behaviors. As Tracy mentioned, that's a key aspect of doing a functional assessment. And then lastly, under proactive, we want to reinforce the desired behaviors. In comparison, a reactive approach has a very limited focus on preventing triggers. There's little focus on teaching new behaviors, if at all, in the form of incidental learning. And then lastly, a punitive response to negative behavior typically produces very adverse outcomes. So you can see a proactive approach is highly favored.
So when we talk about a proactive and reactive approach, it really refers to the ability to intervene successfully at different points in terms of a person's behavior. So you'll see on this slide different points of a crisis. And many of you may be familiar with this cycle of crisis, where we see all the way on the left side of the slide a person's baseline behavior. So they're functioning as usual. And then we have above it listed proactive interventions. So when a person is functioning well, this is a key time to teach new skills. Pete and I talked about this in the second training around when a person is stressed or agitated and their sympathetic nervous system is aroused, it is much more difficult to teach new information. So when a person is functioning reasonably well, this is where we might be doing that scaffolding and skill building. When there's an antecedent, which as we talked about earlier, may be internal or external, could be a fast or slow trigger, but when there's an antecedent, something that is occurring that is upsetting or agitating a person, this is another opportunity to utilize some proactive strategies. Coping skills, reminding a person of their emotion regulation abilities using distraction. It also may be a time where some reactive strategies are utilized. We're going to speak about some reactive strategies in a moment, but reactive strategies might be active listening or bringing the person to a calmer environment. So this phase between the antecedent and the escalation point is really critical, and we may be using a combination, but still the emphasis on the proactive intervention. Once a person exceeds the escalation point, in other words, the interventions haven't been successful, or for some of the people we serve, maybe they haven't used a positive approach, so there's been no interventions up until this point, we hit the crisis, and this is not a time where proactive interventions are effective. A person's capability is exceeded. Their emotion regulation skills are often not being able to be in good control. And so at this stage, the primary focus is reactive strategies. And we do want to have a plan for reactive strategies as part of a PBS. But our main work is in the baseline and in between the antecedent and the escalation phase in terms of a PBS approach.
When speaking of proactive interventions, a crucial aspect is setting and reviewing expectations. These are directions given and reviewed at regular intervals. The directions should be very specific and easily convey the expected behavior. An important point is we want to tell the individual served what we would like them to do rather than what we do not. And we want to state it in affirmative language. It takes some getting used to do this approach, but it is far more effective, especially when we have individuals who might have cognitive impairment in the area of working memory where they don't see different options, especially if emotions are at play. Again, pay attention to the language. So the directive is use a lower inside voice instead of saying stop talking so loudly. Keep your hands down rather than don't hit. Please keep your feet on the floor as opposed to don't kick. Only take things that we will pay for rather than stop stealing from the store. Learning problems and memory deficits, as I mentioned, may interfere with understanding and remembering what constitutes appropriate behavior. Also, individuals with developmental disabilities might experience what are called engrams. They're hot spots in the brain, if you will, where they may not hear the don't part of a direction. So it's very important to state things in affirmative language. Again, learning occurs in small steps, so we have to have realistic expectations, and we want language to be consistent across all settings. We do not want individuals, for example, in the day program to be using one set of expectations and individuals in the home setting using a different set of words.
So it's important to have a good basic toolbox when utilizing positive behavioral support strategies. So I'd like to review some of the integral parts of this toolbox, which are really good clinical skills. So the first is being familiar with the plan itself. And I know both Pete and I have seen where positive behavioral supports are less effective when people don't know how to utilize them, they don't understand the plan, or they're just not familiar with the intricacies of the plan. So this requires a proactive approach in terms of training so that everyone's familiar with the components of the plan. Often Pete and I will do shorthand or 1 to 2 page summaries of the plan so it can be quickly digested for people that may not be as familiar with the intricacies of the plan. Another key component to a toolbox for a PBS approach is avoiding triggers and eliminating, as best we can, provocations. A good understanding of the antecedents, which we spent time talking about during the functional assessment portion of this discussion, really helps us to understand what might cause a person to have a behavior of concern. And if we can minimize or reduce the potential antecedents, we can reduce the likelihood of a behavior of concern happening altogether. So a typical example of this might be a noisy environment. For some people that we serve, an overstimulating environment can be extremely provocative. It can cause behavioral agitation. So if we know this ahead of time, we can minimize that by bringing the person to a quieter environment or trying to reduce the noise in the environment altogether. So that's a good toolbox approach. Avoid what is causing or is one of the factors in terms of the behavior of concern. Positive setting events, prompting and cueing, is really helpful when we're working on teaching a new behavior. When people understand and know what is expected of them, they do far better than when they don't understand or there's confusion. Pete talked about this earlier during the presentation about giving simple and concrete directions, 1 to 2 step directions. So really making sure that the cues and the reviewing of the expectations are clear and understandable. This also helps a person to feel more in control and develop a sense of agency and self-esteem when they understand what's expected of them and they're able to fulfill that. Setting expectations proactively. So helping a person know this is what is expected. When we go into the community, we need to use an indoor voice. We need to keep our hands down by our sides, for example. So giving those proactive setting expectations in a very clear way so that when a person goes out, they know what to do and they feel good about doing it effectively. A daily routine is so critical, and this is often not emphasized enough when we think about the people we serve, how important knowing what is expected during the day and having a day full of activities that are meaningful and also are related to developing skills are really the foundation of everybody's life. Right? So having a predictable, steady routine that has a blend of both leisure activities and skill building can make the biggest difference in terms of a person's ability to move through the stages of change. So daily routine that's predictable also brings a sense of competency and relaxation when one person knows what to expect. And then having that schedule written. So many of us rely on our phones. Now we have all sorts of ways that we rely on a schedule. Well, the people we serve need to have that same schedule as well. So whether it's using adaptive technology like an iPad or an iPhone, or just a written schedule, and it might be even pictures if a person has difficulty with reading, so that they have an understanding of what happens next. That gives a sense of competency and control.
To the end of using pictures, one of the techniques that we have used with individuals who have lower adaptive functioning is actually taking a picture of that individual throughout their day in the schedule, actually showing them completing different tasks or different parts of tasks and what the finished product might look like, and then having that as a reference point for them when we are setting expectations.
Yeah, and I think with our technology abilities, that there's so much more live training and ways to really enhance the schedule, the routine, and skill building. So that's a helpful point. Just a couple more interventions that I want to go over as part of this toolbox for positive behavioral support plans. So concrete directions. So we know that the people we serve have difficulty sometimes in auditory processing or language processing or multi-step directions. So being very concrete with the directions so that they're easily understood, easily encoded, and easily recalled, or recalled with some cueing. Being person-centered and context-centered. So we want to make sure that we're teaching behaviors that are appropriate for that particular context that the person is in, and also being person-centered, making sure that it matches with what's important to the person, right? So whatever toolbox, or if we're using a routine or if we're using adaptive equipment, we want to make sure we're sensitive to what the person really values. Using sensory modalities, really important. So we know with the people that we serve, they sometimes have sensory integration issues or maybe verbal issues that render sensory modalities as being the key way to do emotion regulation. So it can be either an over emphasis on verbal language or sensitivity to the environment. But in either case, we want to make sure that our sensory modalities are implemented in a thoughtful way. So sensory modalities may include soft music, it may include soft touch, it may include aromatherapy, or different ways to utilize the senses to produce emotion regulation and coping skills and soothing. A multimodal approach, so we may be using visual aids, as Pete was talking about. There might be pictures of different behaviors or activities. It might be a to-do list. And also hands-on modeling. Hands-on modeling is so effective, especially when teaching a new skill, helping a person to actually see what is expected and how to do it. So modeling, really important in the early stages of skill acquisition. And then over time, that can be faded out. It can be done together. And then when the person starts to feel more and more independent, the coaching or the modeling can be reduced. Building a team approach, really important for our toolbox. We spoke about this earlier. A team approach is really critical for a positive behavioral support plan. That team approach may include, of course, the person who's receiving services, family members, caregivers, and different people on the team. It might be the one-to-one, paraprofessional, it could be the psychologist, psychiatrist. So just having that regular communication and a team that's working together to service the person, really important. And finally, the last two I wanted to speak about are planned attention. So we know from our functional assessment whether a person sometimes engages in behaviors because they need regular validation and reinforcement. So instead of having to utilize behaviors to get that planned attention, we want to be proactive and give planned attention, which is typically positive praise, as often as we can so that a person feels empowered, that they feel competent, and it can help with the self-esteem building. And it reduces the likelihood of having to utilize behaviors to get the support that the person really needs. So planned attention at regular intervals, we want to have that built in throughout a person's day. And finally, the idea of bringing fresh activities. All of us need novelty and spontaneity, so it's important to include that as well. Sometimes our positive behavioral support plans, because they have such structured activities and routines and interventions, we may lose sight of actually bringing something new and fresh or interesting to the person. So helping them to come up with new ideas, or sometimes just a spontaneous trip or opportunity to learn something new, can bring freshness and vitality into the plan and keep a person invested in wanting to participate in a positive behavioral support plan.
To Tracy's point about the importance of a multimodal approach, I've had instances in my career where I have worked with individuals who have deficits in procedural memory and given them visual and auditory directives and they've not been able to follow. And then when I've converted to doing hands-on modeling for them and walked them through what is being asked in a very grounded, contextually sound way, they're able to do beautifully. The other thing that we want to mention when it comes to the link between functional assessment and intervention is there needs to be a correspondence between the two. A lot of times when looking at other models, for example, that may say attention seeking is the function of behavior, well, if that's being identified, then a corresponding intervention would be planned attention at regular intervals. When it comes to functional assessment, one of the concerns that we have is that a person will identify a function, behaviorists will identify a function, and then offer an intervention that is not related to that.
So as we continue to talk about this toolbox approach, and I want to emphasize too that the toolbox approach is really, these are good clinical skills that people can utilize with all clients, not just people that are getting a positive behavioral support plan. So these are just good clinical skills. So active listening, so really understanding what active listening means, which isn't just listening, but really being present and holding space for a person so that they can articulate and really feel like their needs are being listened to. Affirmative communication, which means saying things in a positive way. Pete spoke about that earlier, about the language and how important it is to say what we expect. But also affirmative communication, the person should feel that they're valued. They want to feel like they are liked. I mean, it's really important. We know that when people have a collaborative relationship, they are much more willing to participate in any kind of intervention. So that collaboration, really important through a affirmative communication style. This goes all the way back to Carl Rogers in the 1960s in the humanistic psychology movement, that the relationship and feeling this unconditional regard is really important in terms of affecting behavioral change. Meaningful and non-contingent activities for quality of life. So this really refers to, again, what makes the person happy, and making sure that regardless of what's going on in the person's life, regardless if they're having behaviors or difficulties, we want to make sure that the person has things that are meaningful and enjoyable. Sometimes behaviorists and family members get into a kind of a trap where they believe that by removing the activities that are most desirable, that it will teach the person a lesson. So if we remove something the person really wants, they'll think more next time and not engage in that behavior. But the research does not show this to be the case. That's a punishment approach. And what the research shows, it actually has the opposite effect. It can cause a person to feel depressed, angry, and disengaged. So it is really important to emphasize, even if a person is really struggling, to not remove things that are important or of value, but actually to emphasize that. We've said over and over during this presentation, when people are happier, it renders many of those maladaptive behaviors unnecessary. So in the heart of a behavioral plan, we want to make sure that in a PBS approach, we have non-contingent activities that enhance a person's well-being. Natural supports, this is also really important. Some of the people we serve are isolated or don't have a lot of supports in their life. So helping to find those, and it could be in a variety of different contexts, whether it's at the gym, a job situation, support groups, AA meetings, there's many opportunities. And so we have to create that and help our people that we serve find these natural supports. Again, that enhances quality of life and decreases some of the maladaptive behaviors. And finally, and we've said this in other slides about the idea of quiet space, really giving people the opportunity to calm down and allow their nervous systems to come back into regulation. Emotion regulation, which is critical, and we talked about that earlier, how often many of the people we serve have difficulties with emotion regulation due to brain deficits. We want to make sure that there are planned times for quiet space. There are relaxing activities that help a person to feel grounded, stable, and out of a fight or flight, or what we might call an over-sympathetic nervous system arousal.
As we mentioned, there is a place for reactive interventions, and let's talk about this a bit more in depth. So reactive interventions are caregivers' actions after a behavior of concern occurs. To reiterate the point, they're for limited use, about 5 to 10% of the time. Reactive strategy should never be the central part of a plan. Reactive strategy should help situations from escalating. For example, redirecting someone away from triggering issues, prompting alternative behaviors, using distractions, and at times establishing control when there's harm to self or others. Reactive interventions might include crisis response teams. For example, Tracy and I do trainings with emergency mobile psychiatric services. Reactive interventions might include hospitalizations and even respite care. Sometimes respite can also be a proactive intervention when it's used in a planned manner. As Tracy has mentioned a number of times, reactive interventions are affected by what's called state-dependent learning. We may lose up to 25 IQ points when we're upset. So getting information in at that point, so to speak, becomes very challenging. And with reactive interventions, just as proactive, we can use multiple modes of entry: verbally mediated directions, visual spatial methods to help the person understand, role modeling, and then contextually driven hands-on approach.
And just to add on to what Pete is sharing, sometimes the reactive and proactive interventions look the same or maybe quite similar, but the intention or the utilization of them is different. So proactive, we're teaching new skills and trying to help our people acquire new skills. Reactive, we're helping with the de-escalation. But often they're one and the same because they're helpful skills in either direction.
And actually, to that point, if we use an intervention proactively, we can always come back and use it reactively, and it actually strengthens the probability that it's going to work in a reactive manner.
So when we talk about reactive interventions, again, not thinking about them as diametrically opposed to proactive, but maybe some enhanced proactive interventions, one of the key things is something called empathic validation. And most of us as caregivers, clinicians, and working with people that have disabilities, we have a lot of empathy, and we pride ourselves on having a lot of empathy. But empathic validation is a particular skill that does need to be taught, and so we spend time in our trainings doing that, working with staff around this piece. So empathic validation refers to one, really actively listening. So active listening means attuning, paying attention, making eye contact, being free from distractions. And then being able to reflect back what the person's experience is. That can be very effective in terms of diffusing negative emotions, just to be able to reflect back. You sound really upset. This sounds like a very upsetting situation for you. Might be an example of that. So validation means acknowledgement. It doesn't mean that a person has to agree with what the person is upset about, but it's just that acknowledgement that this is true. This is what's happening for you right now, and I really understand that. Repeating back the information to make sure that you're understanding it can help the other person that is upset really feel understood and really feel like you care if you're asking to make sure that you're getting it correctly. So sometimes I'll even say, am I correct? Am I getting that? Am I missing anything in what you're sharing with me? I want to make sure I'm really understanding what you're saying, okay? And then sufficiently validating before trying to go on into corrective or making suggestions or changes. So sometimes the empathic validation in itself is sufficient to diffuse a situation. And sometimes some corrective action has to be taken. But spending time with the active validation first can set the groundwork for being able to implement further corrective or reactive strategies, or maybe beginning to utilize some proactive strategies again. And then knowing the context, understanding the setting events, the slow and fast triggers, helping the person who may not even be aware of that, reminding them, hey, I know you had a difficult night last night, you woke up in some pain, perhaps that's why today you're not feeling as well, or you're feeling a little bit vulnerable. So whatever the situation, helping them and also helping the people around the person that may be struggling understand the context. And knowing the individual story. So a person may have anniversary issues. Maybe they suffered a death or a loss at a particular time. Or maybe seasonally, during the winter time, they tend to get more blue. So helping remind them that this time of year tends to be a little harder. It's important to get some light and go for a walk outside, even though there's limited daylight. So understanding the story can help both give more of a context and also maybe identifying some potential triggers that the person may not even be aware of. So those are all keys in terms of empathic validation.
To Tracy's point, empathic validation is an absolutely crucial method when doing reactive interventions. In my days when I was a direct care staff in a hospital setting, I would say 50% of my technique in doing de-escalations centered on empathic validation. When we look at the world of developmental disabilities, Tracy made the point around sufficiently validating. And what that means in real life is to come back and repeat that information, that validation, 2 or 3 times. And I've had instances, for example, working with individuals diagnosed with autism spectrum disorder, where they need to hear that information several times. At the end of the day, some folks may not be interested in solutions. They may be interested in confirmation of what they're going through. And that is a crucial distinction sometimes that we fail to appreciate. We've mentioned a number of times in the presentation thus far that there are proactive and reactive strategies that can be used both ways. And here are some examples of those different coping skills. Again, you can set the expectations of using those proactively and then reiterate them reactively. Anger mapping, for example, is an exercise that someone may look at before anything happens, and then they can refer to that after the fact. We want to be specific, not generic, when it comes down to specific coping strategies, right? Oftentimes when we see poorly done behavioral plans, the plan says we tell the person to use their coping skills, but really what does that mean? We also want to be mindful that asking somebody with poor impulse control to explore or verbalize their feelings of anger might lead them to act on their emotions. That is a very crucial point of understanding. Again, expressing one's feelings can be healthy, but there are some instances, again, in a context of poor impulse control, where it is contraindicated clinically.
And so sometimes what we might consider typical anger management may not be as effective as something like sensory modulation, grounding, and self-soothing. While not addressing directly the triggers to the anger, we're helping a person on a nervous system level to regain control. And then there's more opportunity to explore, perhaps at a later time, what might be some of the antecedents or triggers to the outburst.
Again, thinking about coping strategies, it's about being specific, not generic, and understanding the person that we're working with. Another good example of this is individuals who might suffer from anxiety and panic. There's a group of individuals with that diagnosis who, when they self-focus, it actually makes their symptoms worse, and they're better off doing some external grounding to cope as opposed to doing something like diaphragmatic breathing. So again, know the individual that we're serving. Again, we have some different types of coping strategies. We want to target the person's cognitive strengths. As Tracy and I spoke about in the first video on understanding intellectual disability, if a person, in terms of their intellectual functioning, has visually based strengths, then we want to work to maximize that part of our work with them and to minimize anything that's verbally based. So for example, on the screen, you see some anger management techniques that are based on visual spatial display, right? And some basic, the anger thermometer, if you will, and also the traffic light, what is green light behavior and then versus red light behavior. And sometimes that reference point can be very, very helpful for individuals to better understand what's being asked of them.
So our overarching goal when we're talking about positive behavioral supports are to really help increase targeted, adaptive, and pro-social skills through teaching, through this idea of modeling, through education, through support, and not just trying to reduce the challenging behavior. Many times, and I know both Pete and I have experienced this in our professional life, we'll get referrals based on the maladaptive behaviors. We need this behavior to get under control. The person needs to stop doing this. And so part of this training is really to emphasize the fact that we want to be working on teaching new and adaptive skills. We know that some of the maladaptive behaviors will begin to render themselves completely unnecessary over time if we're sufficiently teaching the positive targeted behaviors. So one way that we can start this process in terms of targeted positive behaviors is something called replacement behaviors. In the beginning, it's really important if a person is engaging in a behavior to get a need met, which we talked about earlier, that every behavior has a particular function. We have to make sure that we're giving them something to replace that behavior. If we tell a person simply to stop doing that behavior, we know that it would be very confusing, because then how does the person get the need met? So I want to talk a little bit about what we call replacement behaviors. The first part of a replacement behavior is we have to make sure that it actually serves the same purpose. If we use a different behavior or ask a person to substitute one behavior for the other, we have to make sure that the outcome is going to be the same. So for example, if someone is screaming to get their needs met, they yell so that people will pay attention. We want to teach them how to get that same need met, to feel heard or to get a request answered, without using a maladaptive behavior. So how to be assertive, how to make sure that their request is being heard, understood, and attended to. So that would be a replacement behavior in terms of communication. Pete talked about this earlier, about the importance of getting reinforcement sooner rather than later. So it is very important if a person is using a new replacement behavior that we reinforce the behavior right away. So the person knows this is what is expected and this is actually helpful as well. If we don't respond quickly, for example, the person who's trying to be polite and assertive to get a behavior and no one pays attention, then they're going to go back to the behavior that did get the need met. So we want to make sure that there's reinforcement quickly to the more proactive, positive target behavior. We also gave the example of self-soothing. Self-soothing needs to be done quickly and it needs to have a positive effect. It has to relieve the distress or it won't be as effective as something that potentially was more harmful, like a cutting behavior. Giving reinforcement is very important. You've heard Pete and I talk about this throughout the video today. And so we want to make sure that we're giving that reinforcement frequently as soon as a person's engaging in a positive targeted behavior. And that gives the message that yes, this is exactly what is helpful and effective. So we want to make sure that we give that reinforcement often. And then following directions and making sure the directions are simple. We've been talking about that with the people we serve. We want to be concrete. Give 1 to 2 step directions. That really is a good rule of thumb in terms of being able to give replacement behaviors and in general when we're cueing and modeling.
One of the reasons why this slide made it into the presentation involves a poignant example from my own clinical work. And I'll share that just to illustrate the point of how important it is to follow the guidelines for replacement behaviors. The reason under getting reinforcement as soon or sooner is I was working with a young man who had significant trauma. Unfortunately, he would awaken in the middle of the night with nightmares, and he learned to ingeniously and adaptively at one point to cut himself to alleviate those nightmares. My recommendation to him was to use ice to soothe himself rather than cutting, which is a classic strategy from the world of dialectical behavioral therapy. Unfortunately, he lived in a dorm environment on the 2nd floor. He would awaken with a nightmare and had to travel all the way down to the kitchen to retrieve the ice and so forth. It would be noisy. So my recommendation to him did not provide him with a very quick way to replace the cutting behavior. My next recommendation to him was to use an instant ice pack which he could break under a pillow, for example, and activate. And we went from having a 50% success rate in replacing the cutting to 100% over the matter of a number of years. So again, understanding the replacement and looking at the guidelines is absolutely crucial because we wanted to serve a number of different criteria.
I spoke about this earlier in terms of the problem with adverse consequences, and I just want to reiterate it because it's really critical in understanding a PBS approach and how it differs from behavioral management. So attempting to control a person's behavior through adverse consequences is different than just natural consequences that evolve when a person engages in a behavior of concern. So what is aversive consequences? So these are a couple of ideas that I want you to consider and also think about how you would avoid these at all cost. So one is ignoring, either spontaneously by just tuning out or not listening to a person or planning to ignore. And I've heard, over the years, sometimes staff give the direction, just ignore the person, they're screaming, but if we ignore them, they'll stop the behavior, right? But that's an aversive consequence, ignoring. Taking away rights and privileges. And this can be done in a variety of ways. So some systems of care have level systems where a person will lose their level if they engage in a certain behavior. Removing reinforcements, I talked about that earlier, a response cost approach. Removing things that are meaningful to the person as a way to punish or teach a lesson. Forcing apologies when they're not genuine. And threatening restraint or seclusion. Now some of these areas may actually be a natural consequence of a behavior. If a person requires mechanical restraints because they're in a very, very dangerous situation, that's different than using it as a threat or a coercion to get somebody to agree or comply in a certain way. We want to avoid coercion at all costs. Minor coercion, what we find over time is that maybe it works once or twice. The research shows punishment might have a very short-term benefit, but over time, it starts to lose its effectiveness, And even more problematically, the person that's utilizing the aversive consequence tends to get more and more punitive and raise their level of coercion in the service of trying to change the behavior. So we want to avoid aversive consequences, and that's a real critical part of our training when we educate our families, our caregivers, and our staff around PBS plans.
Some examples of logical consequences would be that the vehicle stops moving if a person removes their seatbelt, or a person is not permitted to ride their bike unless they're wearing a helmet. So again, for safety reasons, we have logical consequences. A poignant example of the misuse of aversive consequences actually occurred early in my tenure as director here at DDS. I was asked to consult on a case of a young child who was undergoing pretty significant depression, and there was a positive behavioral support plan in place. The plan included copious amounts of planned ignoring. It was used very capriciously by the caregivers and the staff. Unfortunately, this child went from experiencing depression to suicidal ideation because he felt so isolated and withdrawn from others. So again, we have to be very judicious and cautious when using consequences of this nature and try to eliminate them as much as possible. The next part of the presentation focuses on collecting data. Data is very important because it is part of an evidence-based approach. So when we think about evidence-based approaches, there's three components: an empirically supported component, which is data-driven. There's clinical experience as part of that, and then also the preferences of the individual we're working with. So a couple things to think about data collection. First of all, we want to generate what's called a data probe. We want to see what the most salient problem behaviors are to address. Oftentimes people will anecdotally think that something is a problem, a behavior of concern, problematic, but as Tracy said, is it actually impairing that individual's functioning? We want to collect data to identify the frequency, the rate, the intensity, the duration of the challenging behaviors. We want to collect data to identify precipitants. And we want to compare our interventional data, in other words, after we intervene, to the baseline data before we intervene. One of the things that Tracy and I really like when collecting data is to annotate our graphs. In other words, we want to have an indication in the graph around when behavioral interventions have been made, when medication changes have been enacted, when we also want to look at caregiver fidelity with the plan as part of our data collection as well. So here is a really good example of a bar graph with annotated points on it. And you can see where the labels indicate different changes that have taken place. One of the things that we really encourage people to do is not just track behaviors of concern, but we also want to track positive targeted behaviors. So here is a case that I worked with many years ago, and what we did was we were tracking positive targeted behaviors across time. Staying busy instead of isolating, for this individual being helpful to others, and also listening to what others have to say. We went on to actually track this individual's community involvement and so forth. And as you can see, when we started collecting the data, there was actually a peak of positive behaviors, and then across the holidays, her positive behaviors waned. And actually, that became a very telling sign of what was happening for her. She had a number of different family members out of state. She felt very disconnected around the holiday season, and as a result, her targeted positive behaviors declined significantly. So our interventions at that point were actually to bolster her community involvement around the holidays, which helped her actually to move on and live a much more fulfilling life. I doubt that we would have hit on that if it wasn't around the data collection.
And particularly the data collection around the target positive behaviors. Often in absence of maladaptive behaviors, people assume that that is a reflection of a person's growth and change. And it might be, but also it could be they're lying in bed and don't have enough energy to even engage in the maladaptive behaviors. So actually understanding the target positive behaviors in a pictorial way, in a graph way, can give a better reflection or an important reflection of how a person is actually doing in terms of a PBS approach.
Exactly. The graphing tells a story, and if it's nicely done, it can be very informative. So applying our learning, some questions to the practice examples that we're going to provide you. So as you listen to the three practice examples, please ask yourself the following questions. First, what are the key behaviors of concern? 2, what are the functions of the challenging behaviors? And 3, what are the behavioral support strategies, especially proactive interventions, that you might suggest? These are actually cases that we've been involved in, and we hope you find these helpful in applying all the things that we've addressed today. So, our first example, Mr. Jones has severe cognitive deficits. He is nonverbal. He has no history of being aggressive or destructive. One evening, Mr. Jones begins throwing furniture in his group home setting. He was taken to the local emergency room by his staff and seen by a crisis specialist. Mr. Jones was admitted to the hospital and given a provisional diagnosis of psychosis. A couple key points here really speak to the detective work that takes place and cracking the code, if you will. First of all, he's nonverbal, so he can't articulate what's happening with him internally. Secondly, an important feature is that he has no history of behaviors of concern regarding aggressive behavior. As it turns out, in this case, the individual did not have a diagnosis of psychosis whatsoever. Unfortunately, he was quite dehydrated and he became delirious, and as a result of that began acting out as perhaps a means to communicate what he was going through.
And this goes back to the questions we asked earlier about asking the right questions. So starting with that medical approach, particularly when there's a change in behavior.
Yes.
That has been not typical for the person.
Very telling.
So the second example is Ms. Smith is a woman in her 30s who's diagnosed with autism. She does not communicate much with words, but has strong opinions about her likes and dislikes. For many years, Ms. Smith attended a local regional center. She always refused to participate in group activities and community outings, during which she would scream, throw things, and occasionally disrobe. The center staff was incredibly frustrated by her behavior. There were numerous meetings about ways to address Ms. Smith's inappropriate behavior, but nothing worked. So this is a really important example of missing the bigger picture. If we think about the fact that Ms. Smith is not verbal but has strong preferences of likes and dislikes, and if we think about the behavior that she is participating in, what is the function of the behaviors? She's showing her likes and dislikes. So if she is screaming, throwing things, and occasionally disrobing, she is displaying strong indications of dislike and not having preferences to be in this particular activity or environment. And the staff are missing this piece, right, by continuing to meet about her, trying to work with the behavior, instead of changing the behavior itself, changing the environment itself. So sometimes an environmental approach of inviting Ms. Smith to do quieter one-on-one individualized activities that are less stressful can ameliorate the behavior, and that's exactly what happened. Helping her to get one-to-one planned activities, art therapy, breathing, yoga, doing some interventions like that were much more effective because her behaviors were very different. She was smiling, she was able to engage, and she was much calmer, showing, in fact, her preference for those type of individual preferences.
To Tracy's point, a key feature in this one illustration was around Mrs. Smith carrying the autism diagnosis and the sensory integration issues she had around crowds and noisy environments. And again, to Tracy's point, when Mrs. Smith was provided with individualized supports in an environment that she preferred, the behaviors of concern simply went by the wayside. In our last example.
Our last example, Jesse is a 14-year-old high school freshman who receives special education. He's the older of 2 siblings with a younger sister who is 12. He lives with his parents and siblings in an intact home. He's been diagnosed with mild intellectual disability and autism spectrum disorder. Jesse has problems communicating, especially when he gets distressed. He's also been diagnosed with depression and ADHD, attention deficit hyperactivity disorder. He is prescribed Adderall, Paxil, and Risperidol, but the effectiveness of the medications is questionable. Jesse has experimented with marijuana given to him by his cousin, which Jesse feels helps him to focus better and feels less depressed. Jesse's been having difficulties now in school, including being bullied, and lately he's refused to go to school. Jesse claims he has no friends and thinks he will be a failure in life. His only goal is to stay at home and play video games late into the night, describing this as his only escape. When his family tries to get him to go, he's become verbally aggressive toward his mother and sister. On a recent occasion, Jesse struck out and hit his father. Both parents were scared and unsure what to do next. Emergency mobile psychiatric services was called, and his parents tried through consequences, taking away his phone and his PlayStation, but it still seemed to have made Jesse's behavior worse. He feels controlled. His family would like Jesse to go to counseling to discuss his developmental disabilities and his school stresses, but he has adamantly refused.
So here we have a very complex case with multiple features to it. In this instance, one of the things I recall is that the assessment of the entire picture to get the gestalt of what's happening was very important.
Right. And we can see multi-factors in here with his intellectual disability, with the autism spectrum diagnosis, but also some of the psychiatric components of feeling quite depressed, having poorly mediated ADHD perhaps, and having difficulty maintaining his composure, becoming aggressive, and the substance use piece, which may or may not be a significant component, but needs further exploration as well. So that really critical component of doing a good assessment to understanding Jesse's functioning is recommended. And also the other piece that I think is mentioned in here is Jesse's readiness for change. This goes back to our stage of change model, that last piece about Jesse adamantly refusing and being pushed. We know, as we talked earlier, how this can have a deleterious effect on a person's willingness to receive treatment if they're pushing or feeling pushed and they're not ready for change. So this example highlights the importance of doing a good assessment to understanding a person's stage of change, and also really supporting the family and the support system, who are all trying to really help Jesse out of a very difficult situation.
One of the things this case also illustrates is that a case conceptualization is an ongoing and evolving task, and it's something to appreciate that information unfolds as we work through particular problems.
We see also how failed behavioral strategies, coercion and punishment, right, the consequences of taking away things often have an adverse effect. And often we see that, after the fact, we recognize, oh, that was actually a further trigger to depression or ongoing aggression. So this is a very typical example of what some of the folks that we train in our mobile crisis units encounter, and working with families that are really struggling when clients are complex like Jesse and have multiple psychiatric and developmental challenges to work with.
Thank you, Tracy, very much for presenting.
Thanks.
We hope that you found the video to be informative. If you have any questions, please reach out to us at the contact information that's noted on the screen. Thank you.
Thank you.